Right. Hey guys, welcome to my video. So today, basically, I'm going to be talking about drug metabolism and how different drugs are metabolized. So you got phase one metabolism, phase two. I'm just going to be looking into a bit of detail on the various routes of metabolism. So what actually happens and the whole procedure. So this video here is created by using one of my lecture slides given to me from one of my lectures. So the PowerPoint is not exactly created by me, so all credits goes to Dr. Dankar who have put this PowerPoint together. But I'm just using it to create this video because I feel like the PowerPoint was very excellently laid out and it's very easy to follow through. So in order for a drug to work, you need an adequate concentration in the drug tissues, right? So we know that. What we call is we have this process called ADME. So you can see ADME. So when a drug is first administered, you've got absorption. Then next takes place as distribution. So this is when the drug is distributed to various different types of tissues. Then once it reaches the liver, the gut wall and stuff, it becomes metabolized, and then some of the drugs, as you know, is excreted. So here you can see a plasma concentration curve. So on your left, on your y-axis, you've got plasma concentration. So this is the amount of drug present in your plasma, and then on the x-axis, you've got the time. So as you can see, over here is where you first administered the drug, and then as the time goes along, you can see the absorption, the plasma concentration increases because this is because the drug is being dissolved in your plasma. Right. After a certain amount of time, this peak here is also known as the Cmax, and in most drugs, for example, like gentamicin and antibiotics, they usually take about an hour, right? And then as you can see, so this is the Cmax. Cmax is the maximum concentration. Now, over here, as you go down, this is known as the distribution. So now the drug is going from the plasma, so from the blood, and is being distributed to various different parts of the body. And metabolism also takes place, so therefore, the drug's made more hydrophilic, so more water soluble, and it's also made polar. And then as you go down, elimination happens, so you eliminate drugs via urine, sweat, your breath, and many more different ways. Now, the administration of drugs can be very in different ways, but most of us, when we go to a GP or something, they usually give us a tablet, and this is known as oral administration. Right, so you've got oral administration here, and that usually goes via your esophagus down into your stomach, into your intestines, where most of the absorption takes place. And then from your gut, it goes into the portal system, into the liver, where it's metabolized, and then from the hepatic vein back around to the heart, into the lungs, and then to the systemic circulation. Another example of administration is precutaneous. So this is basically when you apply it to the skin, cutaneous, precutaneous. So you have topical creams, sprays, and stuff that you can administer to the skin. Intravenous is basically an injection, so it injects right into the veins. And you can have intramuscular, so fungal medications are usually intramuscular. Now you got intrathecal, which is basically injecting into it's basically a process of lumbar puncture where you inject the medication into the spinal cord and into the CSF, so the cerebral spinal fluid. So this is used to treat fungal meningitis and various different conditions like that, or meningitis in the brain. The next one is inhalation. So many of you were aware of the condition called asthma, where we take salbutamol, and it comes in two different types of pump, a brown and a blue one, right? So inhalation via lungs is another one. And on the right here, you can see the different types of elimination that takes place. So you can eliminate it via urine, feces, milk, sweat. So mums, um, from mothers when they're breastfeeding their child, sometimes there is a likelihood of toxicity because of drugs being excreted through milk, and this can then affect the um, baby who's feeding on the milk, sweat, as well as expired air. Right, so just mentioned through this, I'm just going to go through very quickly. So oral is the most favorable by many drug companies, is much more easy. Sublingual is basically when you spray the drug under your tongue in the buccal cavity. An example of this is glycerol trinitrate. This is used to cure for angina. Rectal is usually when you go down to the hospital, they do a rectal examination, and they put a tablet down inside your anus. This is basically also known as rectal administrations. For example, like diazepam, which is a muscle relaxant, or for other examples like ulcerative colitis, so somewhere where you need some sort of relaxation very quickly. Other epical surfaces usually include the skin, your eye, the cornea of the eye, the vagina. The vagina is very prone to bacterial infection, um, bacillus. There is a bacteria like that, and the nasal mucosa, injections, and inhalations. So, routes of administration can be classified into very simple terminology known as topical administration. So, this is basically the skin, and systemic. So, this usually goes inside the body. So, topical meaning outside of the body, and systemic into the body. And then systemic can be then classified into two different ones. So, you've got internal administration. So, this is basically where you take it in through your mouth. So, mostly capsules, tablets. So whatever encounters the GI tract, so it goes through your stomach and into your intestines, is known as internal administration. Whatever goes directly into your plasma without encountering the GI tract is known as parenteral. So examples use inhalations, intramuscular, intravenous, intraarterial injections, and so on. Right. So we've had a look at internal administration. So usually it's oral. Most patients take it, and the key fundamental aspect that you need to remember is that enteric coated. So most of them are enteric coated. This allows them to have a longer time in your body, so it's a slower release. Hence, it has a much more greater effect. Instead of tablets, you can also have solutions. So you might have taken Gaviscon for heartburn, chesty cough, various different solutions, emulsion, suspension, tablets, and capsules. The oral dosage is foam. Solution is the quickest to get in because of it's already in a solution. It's already in a liquid form, so it has a very high large surface area in order for it to cross the GI tract, the intestinal membrane. Emulsion is slightly more harder. Suspension is much more thicker. Tablet is much more harder because usually it's in a solid form, and once it gets into the stomach, it needs to be broken down into fine pieces, so it increases surface area, then taken into the body. And capsule is similar as well. So sublingual, as I mentioned earlier, it's angina spray, usually for very fast effect. So good for drugs which are unstable at gastric pH, and usually has a very, very quick effect because it gets rapidly into your plasma concentration. Now, rectal administration, as I said before, is to produce a local effect, sometimes anti-inflammatories, so like diazepam, which is used muscle relaxant, or NSAIDs, used for ulcerative colitis. So this is a condition where your colons develop ulcer. Right, so you prescribe painkillers like omeprazole and different things for doctors would. Useful method for patients who are unable to take medication by mouth. So basically, someone who's just had a post-operation, or they're usually not good with swallowing tablets due to the fact that they vomit a lot, or diazepam cannot be in patients who are epileptic, so they have muscle spasms, regular muscle spasms. and this will make it very hard for the healthcare professional to administrate the diazepam via intravenous methods. So the best way is rectal, because it usually involves the patient not lying down, and it's much more easier procedure. But at the end of the day, they all have the same procedure, same effect. Sorry. Now, cutaneous administration usually include topical steroid creams, so you can have antifungal creams, antibacterial creams. Significant absorption can occur to leading systemic effects. So the main one, when your parents get old or something, people complain with back pain and stuff. This is usually rub-on gels like Voltrol is the main one you've probably seen advertised in your local pharmacy or on the internet or somewhere. And this basically is an anti-inflammatory non-steroidal NSAID, so non-steroidal anti-inflammatory. It contains the molecule called diclofenac, which is a pain reliever. You can also have transdermal patches, so estrogen and testosterone hormone replacements for birth control and stuff. Fentanyl patches for treatment of breakthrough pain. Nicotinic patches for those who are trying to get off smoking, but yet still they want that effect that you get from taking nicotine. So these patches usually release nicotine into your blood concentration very slowly, so it keeps the person feeling almost as if they've had a cigarette to smoke. Now, nasal sprays usually include the very like Vicks and things like that you can usually take in order for because you're feeling a fever or you're ill. Absorption usually takes place over the nasal mucosa. Now, when you go to your eye test, sometimes they have eye drops, and this is basically dorsalamide used to lower ocular pressure and treat patients with glaucoma. Sometimes they usually use an antibacterial or something which they can put in the cornea of your eye, and hence why it makes it very hard for us to open our eye. And this is another way of applying to epithelial surface. So, like mentioned before, the different surfaces of epithelia include the skin, so analgesics like painkillers, antibiotics, antifungals can be applied there. The cornea includes things like dorsalamide to treat ocular pressure. Vagina, you can rub the antibacterial cream, antifungal, various different types. Nasal mucosa like nasal sprays. So these are all the different types of percutaneous ways of administration. Now, parenteral administration. So this is basically remember back, the systemic circulation is split into internal, so ones that go directly via into the GI tract, and the other one is parenteral, so the ones that usually go that don't go to the GI tract and they go directly into the plasma concentration. So these have a much more faster and more rapid effect. Examples usually include intradermal, intravenous, intramuscular, intraarterial, intrathecal, intraperitoneal. So this is intraperitoneal is like when you have an injection for things like peritonitis, and it's usually not commonly administered to humans, and it's mainly administered to in animals rather than humans. But yeah, it's still a way of administrating by injection. So sometimes intradermal subcutaneous might be the fact that your healthcare professional would give you an injection on the top of your arm, as you can see the lady here, or sometimes they can give it to you in your bottom side. Intravenous is usually taken in your medial cubital vein, which is usually found round about near your elbow. Intraarterial is like the brachial artery or something. When they put a cannula in, when doctors or nurses put a cannula in, they usually go for the veins that's present superficial on your palm, on your wrist, or sometimes they can put it directly into your medial cubital vein as well. Intrathecal, like I said, is drugs administered to cure infections in the central nervous system, like fungal meningitis, and this is done via lumbar puncture. So usually make the patient lie down on their backside and inject it with a very long needle into the spine, and this is usually given between the regions of L3 to L4, so just above your hip. Interperitoneal is your stomach, as I said before. Now, administration by injection is much more faster. Bolus injection rapidly produces very high concentrations. So, if we were to look at the plasma concentration curve for IV administration compared to an oral administration, you would see the plasma concentration, the Cmax. The Cmax would be the same because at the end of the day, the drug has the same effect, but the time taken to reach the Cmax will be much more less in the IV injection because it's much more rapid. It goes directly into the plasma membrane. As well as that, with oral ones, it usually has to go through a massive process where it goes into the GI tract, it has to be absorbed, and then it goes around to the liver, also known as the first pass effect, where it becomes metabolized into phase 1 constituents and then phase 2. So various processes like that increase the excretion, so you might not get the Cmax to be the same, but almost same as well. Seen many drug addicts and stuff usually inject themselves with cocaine, morphine, and various things like that. And why they do it is because for a rapid relief. Peak concentration is dependent on the rate of injection. Okay. Subcutaneous or intramuscular injection, like I said before, so includes the upper arm or the buttocks. So if you've ever had some sort of accidentally walked over a needle or some sort of rusty pin that was lying around where your dad was working in the house for just doing a DIY, you might have been rushed to the hospital because they would have given you most probably an injection in your upper arm or your buttock, and this is basically to prevent the spread of any infections or anything like that. Now, so that's a systemic effect. Why they give it there is because usually when the pin or something that usually you encounter and it pierces your body can have an effect where it spreads through your tissues rather than straight into your blood vessels. Now, so here you go. This is the administration via injection. So an example of this methotrexate. So this is usually given to kids who develop childhood leukemia. So it's a type of blood cancer, to prevent relapse in the CNS. So here you can see that it's usually between the L3 and lumbar 4 region, and they usually use this very long type of needle, lumbar puncture needle, and it's usually done by an anesthetic, I think, someone very special. It can't be done by a regular doctor, I know that. They usually puncture it straight into your L3 region, into the subarachnoid space, and into the CSF. So to try not to, puncture it so bad, but it's very, very, very sharp needle, as you can see from the photo here, and it's usually done by very professional healthcare. Lung effects, like I said, asthma and things like that usually use bronchodilators such as salbutamol to achieve a high local drug concentration, minimize systemic effects. Now, absorption is very key because the understanding of this is very important in a sense that it is quite hard because so oral administrations, so things like internal administrations usually has to cross the GI tract, and it can be very hard. So here Dr. Darkhan has listed, Dan Carr, has listed the various different ways of administration. So here, if you just follow how a drug goes through, so if we were to take it, goes down the esophagus, through the fundus of the stomach, down under the bottom, greater curvature, lesser curvature, through the pyloric antrum, into the and the sphincter opens into the duodenum and into your small intestine, and from your small intestine it gets traveled down your large intestine to your ascending colon, transverse, descending, and then back around to your hepatic portal system and into the liver. So the greatest amount of absorption usually takes place within the intestines, and we'll get onto that in a bit, why that is. But most drugs, as you know, as you're aware, the stomach usually has very high acidic conditions. So most drugs can be broken down due to the high acidic conditions. But nowadays, most oral administered capsules and tablets are acid resistant, so they usually get into the intestines without being broken down. Now, once they get into the intestines, there's various different mechanisms through which they are absorbed, right? Sorry, this is basically known as transcellular. So they can be absorbed by passive diffusion. So this is simply crossing over the crossing into the bloodstream, or they can be crossed over by facilitated diffusion, active transport, which uses ATP, penocytosis, and they can also go between the cells via gap junctions, like gap junctions or tight or connexins or cadherins, various things like that. So transcellular is basically direct passive diffusion, no polar chemicals concentration gradient. Right, facilitated diffusion usually involves a carrier protein, but it's also a passive process. The active transport is an active process because it makes use of ATP and it uses the energy. It's a very complex method. If you look into the biochemistry of how it works, it's a very complex method, but we're not going to go into detail. And penocytosis as well, which is not mentioned in the slide. But here you can see this is the extracellular. So this is probably the lumen of the gut, and this is the epithelial surface. So you can imagine the microvilli surrounding it, as well as the brush border, the ciliated microvilli brush border on top. And this is the intracellular. So once they go in through the enterocytes, which is known as the cells, and then into down here would be the blood capillaries that surround the GI tract. So sometimes non-lipophilic drugs, so ones that are not very dissolvable, usually usually pass through via paracellular methods. Paracellular means going through within the lungs, and this usually happens between the gaps, so the gap junctions, the desmosomes, and so on, etc., and then into the blood capillary. So this transcellular and paracellular methods. Transcellular is for lipophilic drugs, and paracellular for non-lipophilic drugs. Now, there's various factors affecting the passage of drugs through cell membranes. So the first one is, as you can see, is hydrosolubility. Right, and here the lipid solubility, the water solubility. So the more hydrophilic the drug is, so the more water soluble it is, much easier for it to be dissolved. So that's a key factor that affects drug absorption in the small intestine. Lipid solubility. So the higher the lipophilicity, the less well it's absorbed. And we have some a parameter that we call log D 7.4, and I'll explain that. Usually if the log D 7.4 of the drug is above 0, that means it's usually well absorbed via transcellular method, so via the passive, active, facilitated diffusion through the enterocytes. But if you have a log D 7.4 less than 0, it's usually not so greatly absorbed. It's poor absorption via paracellular method. Now, the degree of ionization is also very important. So if you've done A-level chemistry and stuff, you would know about the Henderson-Hasselbalch, the pKa and the Ka values. Usually, pharmaceutical companies recommend a pKa of between 6 to 8 for the best absorption. So the higher if it's above that, then it's going to physically affect the way the drugs are absorbed. So less absorption, and if it's below that pK as well, it will be the absorption will be much more less as well. Molecular weight, not very critical factor, but so the main things, the physiochemical factors that you need to take into consideration is the water solubility, so the hydrophilicity, lipid solubility. So the more lipid soluble it is, the less easily it's absorbed, and this parameter log D 7.4, degree of ionization, and molecular weight. Now there are other things like biological factors that also affect it, and these are very few. These are very few biological factors mentioned here. There's much more greater ones that's going to come up in later on stage. So you have things like plasma protein binding. So the fundamental pharmacology is, here is the key part. It's you have proteins like albumin traveling around your blood, and usually a drug or a protein cannot travel by itself, and usually is bound to another molecule. So albumin is a blood protein that usually binds onto various other proteins, and this means that this drug is usually in a bound state. So here, drugs are only effective when they're in the unbound, so when they're not bound to some sort of plasma protein, they're by themselves, so they then can go on to the required site of action and then bind to the active site and then cause various cascades of reactions and bring about the systemic effect, right? Sometimes it's called when they're bound to plasma proteins, then it's hard because they're not free and they're bound. So the best way for a drug to be absorbed is usually in the unbound state. But most drugs, once they get into the blood, they become bound to this plasma protein like ubiquinone, albumin, etc. Some are stored in adipose tissue, so this is fat cells, and binding to tissue proteins, so macromolecules. Now, what I forgot to mention is there are also factors in the physiochemical factors. So if we go back over here, the enterocytes, so what's made up as the epithelial surface, the epithelial cells, also referred to as the enterocytes, usually have other proteins on their surface known as efflux and influx protein. So proteins via which these drugs get in through, and we'll go into a bit more detail in later lectures on how they do. So there's things like P-glycoprotein as mentioned here, which helps with active transport, but that's an efflux protein, and it affects the way the drug is absorbed into the blood capillaries. So drug lipophilicity is usually measured using this thing also known as octanol or aqueous layer. So you have octanol here, which is an organic solvent, and then you have the aqueous layer. So what you do is you just simply do the concentration of the organic solvent divided by the concentration of the aqueous phase, and then you get this value parameter log D 7.4, and if it's above 0, then it's usually well absorbed, whereas if it's below, then it's usually not so well absorbed. So you can see increasing the log D.7.4 will decrease renal clearance and increase metabolic clearance. So as you said before, so if it's above 0, it's usually well absorbed. So as you can see, above 0 is well absorbed transcellularly, which means that it will decrease the renal clearance. So less drug is lost via your urine and things like that. Problem with this is increases the metabolic clearance, and this can lead to high because there's something known as therapeutic window, which I will touch on in subsequent lectures. So, for example, usually when a drug is administered, you have um, a minimum concentration. So the plasma concentration has to go above that limit, so the lower bound basically in terms of maths, in order for that drug to be effective. But then there's also an upper bound, which is also known as the toxic level. So once the plasma concentration crosses that, then the drug becomes toxic, and then it can cause various unwanted side effects. So if you have a log D 7.4, which of a very high number, so much more higher than like 2, usually your renal clearance is very low, and which means your metabolic clearance, so within your plasma, is very high. So a lot of drug gets into the tissue, and then this can cause toxicity. So drug companies usually want a very log P value. Log P is just another term for log D 7.4. So they want it to be above 0, so it's well absorbed, but they don't want it to be too high that it causes toxicity. So usually between 1 and 2. So this is very different examples of different administrations and the log P value, log D 7.4 values. So you can see intestinal absorption is great and best between 1.35. Sublingual is 5.5, and that's only because it has to be very highly, very rapidly absorbed into the body, and so on. So when they have a very high log D 7.4, you would have noticed that these medications have a very, very, very low dosage. So they're usually in the micrograms or very less low numbers of milligrams, whereas paracetamols and things like that, which have an intestinal absorption of 1.35, which is fairly low, usually has a very high concentration of dosage, so about 250 milligrams, 500 milligrams. There's even paracetamols which can go up to 1,000 milligram absorption. So we've gone through all of this. Drug ionization, like I said before, high degree of ionization usually keeps the drugs out of the cells and decreases systemic toxicity. But you don't want a very high degree of ionization. If you don't know what ionization means, simply just type it into Google. It's the extent to which the drug is charged. And pKa, so this is using the chemistry here, a bit of A-level chemistry. This is basically log of Ka, pKa. In range between 6 to 8 is very advantageous for membrane penetration. So it's also very well absorbed, as well as not having a very great systemic toxic effect. So a pK range between 6 to 8 is good. Now, this was one of the biological factors. So we've just gone through the different physiochemical factors in detail. Now, the biological factors, like I said before, drug and protein form this reversible structure called drug-protein complex. So, as you can see here, unbound drug is pharmacologically active, so it's best to have unbound drugs, but you don't want them to be always unbound, because when they travel through your blood system, you only want them to be active when they reach that specific site. So it's much better for them to be bound when they're traveling through the different areas which doesn't require the drugs. For example, if you have some sort of antibacterial infection in your I don't know, let's say you're near your um, near your armpits or something like that, you don't want the drug to be effective near your elbows. You want it to be effective near the armpits. So therefore, it's only once those drugs get there that they become unbound and they become pharmacologically active. So the three main proteins mentioned before. One I mentioned in particular, which is what you should know, is albumin. There's B globulin and acid glycoprotein. So acidic drugs like warfarin, so anticoagulant, NSAIDs, analgesics, sulfonamides, and antidepressants like fluoxetine, and there's many different ones, is used. And these are usually the more common ones like warfarin, NSAIDs, antidepressants are mainly bound to the plasma protein albumin. Beta globulin usually binds to some basic drugs, and acid glycoprotein. So these are the three main proteins that you should be aware of: albumin, beta globulin, and acid glycoprotein. The amount bound usually depends on the concentration of free drug, affinity of the binding site. So we've gone through this. Now, internal absorption of drugs. Yeah, so going through all of this. Yep, so absorption of I said most of the drug is absorbed in the small intestine, and that might have led you on to thinking, why can't it be absorbed in the large intestine or the bowels? Sorry, not the bowels. Bowels is a common term for the whole of the GI tract. In the large intestine. Well, it's because the small intestine usually has a very large surface area, very high blood flow, so very high blood velocity, above a litre per minute. And the surface area is about 200 meters squared. So compared to the stomach, which is simply just 200 times less, basically, so it's only 1 meter squared. So you can see the surface area. And you know from biology that surface area affects the rate of absorption. So the greater the surface area, the much more absorption you have of the drug. So that's one reason. A high blood flow also means that as drugs is being absorbed, they're constantly being removed. So there's always that concentration gradient which is maintained. So more drugs can easily pass into the blood capillaries. And then bile also helps some drugs like digoxin, which is usually used in antiarrhythmic, so arrhythmias in heart disease. Griseofulvin, which is an antifungal drug, which blocks DNA and RNA synthesis. So bile also helps solubilize some drugs. Bile is usually secreted from the liver and into the intestine, where it's also acted upon with pancreatic juice and stuff secreted by the pancreas. So these all makes the drug less lipophilic. So the bile, breaks down fats and stuff. So it breaks down the fat around it, so making it less lipophilic, more hydrophilic, so more water soluble. So it can be easily absorbed, because usually these drugs like griseofulvin, digoxin are usually very highly lipophilic and usually very poorly water soluble, so it's very hard for it to be absorbed. So this is a simple which formulation gets into the blood faster. So you know the solution, because it has a much greater surface area. It's already in the format that you want it to be, because once the tablet usually breaks down into granules and then into solution. Now, larger surface area, as I mentioned, so tablet slower, solution fastest. Now, factors that can influence GI absorption. So we mentioned physiochemical factors. We also mentioned formulation. So solution is the greatest rate of absorption, and then tablet is usually the smallest rate of absorption. Another key one was biological factors that we mentioned, like drug binding, how many unbound drug is available. Other things that we didn't mention, what you need to be aware of, is the gut pH, the gut motility, so how well it's moving its contents down into the intestine. Perfusion, which is very important, is the small intestine getting the required blood flow. Bile flow, malabsorption states, and various other ones. So just keep that in the back of your mind as well. So gut pH, the gut motility rate, perfusion rate, the flow, bile flow, these all affect the way drugs can also get in. So if someone has some sort of end-stage liver disease, or sometimes where their gallbladder is usually inflamed, so hypertrophy takes place of the bile of the gallbladder, um, like cholecystitis, um, is a process by which you remove it. Um, Patients won't be able to secrete bile, which means that drugs like digoxin and the antifungal griseofulvin, which are highly lipophilic, won't be able to be made less lipophilic because there's less bile being excreted. Also, your doctor would have informed you when when you take antibiotics like tetracycline or other drugs, they usually tell you when to take the drug. So if a doctor doesn't tell you, you can likewise ask your pharmacist, they would know this. Sometimes most drugs are taken with food because of their high side effects, which can cause upper GI bleeding and etc. But there are some other drugs like tetracycline which could be affected with milk and things like that. So usually it's best to be taken in an empty stomach by itself. So drug to drug interactions also influences the GI absorption. So stomach emptying time, anticholinergics, laxatives are usually given to increase the motility if you feel some sort of constipation. Cardiovascular drugs usually decrease the perfusion because it usually lowers the blood pressure and things like that. So another key thing was charcoal, which is usually given to patients who have just had some sort of food poisoning or something like that. They usually give charcoal to patients like that. Well, drug to drug interaction. So if you're already taking a drug and you're going to be administering a second drug, usually the doctor sees if there's some sort of drug to drug interaction because they can compete for the same active site, or sometimes they can produce some sort of toxic effects because of the effects of both of them via synergy, which is like when both of them combine together to produce an adverse effect. Now, phase one. So, so we've talked about absorption, we've talked about distribution. Now, we need to talk about metabolism and then excretion. So, metabolism is I think it's one of the most hardest parts of this lecture because it's usually not well understood by students and it's very hard to remember all the different concepts of metabolism. Right, so why do we have drug metabolism? So the simple answer is most drugs are lipophilic and they're non-polar. So this means that they're very not so easily absorbed and it's much more harder to be absorbed. Lipophilic means you want potentially, inevitably, you want the drug to be less lipophilic, which means that it will be more hydrophilic, so more water soluble, and you want it to have some sort of polar effects. So this then increases the excretion via urine, feces, as well as absorption into the gut, as we saw earlier. So these are all factors that affect it. So these are the physiochemical factors. Ooh, I just found that quite amusing how it can turn big. But yeah, liver is the main site of drug metabolism, but not just restricted there. The gut also has some sort of metabolizing effects, which we'll look in later stage. But the liver, for now, is the main site of metabolism that you should be aware of, and it contains enzymes known as Cytochrome P450. and there's different classes of that as well. So take home message from this slide is you want it to be more hydrophilic and more polar, so it increases the excretion, reduces toxicity, much more greater absorption. You want the drug to be effective rather than just being wasted. So, like I said, we study the drug metabolism due to toxicity and altered pharmacological effect. So before we go into this, drug metabolism is usually split into two phases. So phase 1, and then you've got phase 2. So as you can see, as you go across, the drug grows across phase 1. Before it was metabolized by phase 1, the excretion, you can see the size of the arrow is usually very small, so there was less excretion. But as you go down after phase 1, it becomes much bigger, so there's a much greater excretion, but there isn't a very, very significant effect. But it's only after phase 2 that the excretion has a very large effect, leading to greater excretion. So polarity also increases, so making it more polar as you go down, as from when the drug is first enters the liver, and as it's metabolized, it becomes more polar as well, which also contributes to the excretion, as mentioned earlier. So phase 1 usually includes very small changes like oxidation and reduction, hydrolysis, and the whole purpose of phase 1 is just to functionalize the drug and make it more actively ready for phase 2. So functionalize the drug. Phase 2 is the process by which conjugation reactions take place. So in this way you have a conjugate a different molecule, which is like a donor, usually gives you some sort of a side chain or a molecule which you then add on to your drug, which makes it more water soluble, less lipophilic, more polar, which also then increases excretion. But as you can see, most of the excretion, if you go back here, the most amount of effect is usually from phase 2. There is a very low effect produced after phase 1. The excretion rate is not so high, but it is there. But phase 2 is what causes the excretion and the absorption and everything to become very high, and very high. So they study this drug metabolism. Usually they in laboratories and stuff, scientists, PhD students, and various different healthcare graduates usually study this. They usually isolate perfused hepatocytes. Hepatocytes are functional units of a liver, and what they do is they usually administer the drugs. And before that, they usually use this thing called collagenase, which breaks up the collagen. So that's the connective tissue that holds together all the hepatocytes. So, and collagenase usually breaks up the cell bonds and makes them individual, and then you put them down a microscope and you administer the drug, and then you measure using a mass spectrometer or chromatography, how much drug is absorbed. So yeah, so this is the key slide that you want to try to memorize. So phase 1 usually involves oxidation, reduction, hydrolysis, and the whole purpose of this is to functionalize the drug. So oxidation is basically an addition of oxygen, or it can be a loss of hydrogen, you could say. But the end effect of all of this would be the lipophilicity does go down, but it's very small, as you can see here, and there's a very slight increase in excretion. And the pharmacological effect, so does it increase it or decrease it? It can vary. But phase 1 usually does have some sort of effect, but it's very, very little, as you can see from here. So the main purpose of phase 1 is to functionalize the drug and make it ready for phase 2. So the main three reactions that takes place is oxidation, reduction, and hydrolysis. But once you get to phase 2, what phase 2 does is conjugation. So there's an addition of a larger group of molecules, so it's often charged, and this is often given by a donor, and they have various different types of enzymes and cofactors that play key roles, and we'll go through each of them in a minute. So, but you can see the consequences are that once phase 2 takes place, the drugs have a very large decrease in lipophilicity, so it means it makes it very highly hydrophilic. The excretion is usually very, very highly increased, and usually the pharmacological effect but is on the downside, so it usually decreases it. But as you can see, phase 2 creates a much more significant effect compared to phase 1, let's say. Sorry, hold on. I was just going to... Yeah, so phase 1, oxidation, reduction, and hydrolysis. Now we'll look into phase 1 in a bit more detail now. So sorry, I accidentally pressed Control P, which made the screen come up to the print screen. So oxidation. I was just looking for... No, I'll find it. Okay, so oxidation by cytochrome P450. So phase 1, the oxidation can be split into two different ones. So oxidation usually takes place by the most abundant enzyme found in the liver, which is cytochrome P450. Also, it can be by non-P450 oxidation. Now, if you don't know what oxidation is, you might want to search up what oxidation means. You can easily go on websites like ChemGuide or just type into Google define oxidation, and it should give you an easy definition. Now, there's about 10 different ones that you need to learn. So the first one is aliphatic hydroxylation. Next one is aromatic, so usually includes compounds which are circular, like benzene and things like that. Epoxidation, which you might have not come across as the first time. Usually found in drugs like carbamazepine, usually administered for conditions like epilepsy. Dealkylation, found in like drugs like codeine, which can be dealkylated into morphine. So dealkylation usually includes three sub-processes like N-dealkylation, so there's a removal of the removal of the alkyl group from the nitrogen, O-dealkylation, removal from the oxygen, and S is removal from the sulfur. Right, next is deamination, so this is removal of amino groups, so you end up having a byproduct of ammonia, NH3. N-oxidation and X-oxidation is something that you wouldn't have come across, so these guys are the main one, dealkylation. But N-oxidation and S-oxidation is also important. Next is alcohol oxidation. So this is a process of converting an alcohol into an aldehyde and water. Dehydrogenation is the removal of hydrogens. It also produces water as a side effect, and dehalogenation is removal of halogens like chlorine, fluorine, bromine, and things like that. So just to recap, the 10 different ones are aliphatic hydroxylation. So hydroxylation means an addition of an OH group, hydroxy. 2 is aromatic, 3 is epoxidation, 4 is dealkylation, which includes NOS, deamination is 5, N-oxidation 6, 7 is S-oxidation, alcohol oxidation, dehydrogenation, and dehalogenation. So as you can see, most important enzyme involved in the metabolism of drug within the liver, or the most abundant in terms of the whole body, is usually cytochrome P450, and it has a very super family of enzymes with overlapping substrate, and is also involved in vitamin A and D metabolism as well. Hence, sometimes when patients have some sort of liver deficiencies, they can't usually synthesize vitamin A or vitamin D or even vitamin K. Sometimes vitamin K is usually involved in blood clotting factors. So now you might be wondering where they get this fancy number 450 from. That's basically simple. It's because when they had used the cytochrome, the protein, in the presence of carbon monoxide, they found that the maximum absorption was at 450 nanometers, so they simply call it P450. Now, the main and the key aspect that you want to look into and learn is that they have this prosthetic group. So prosthetic groups are anything like a side chain that's added usually to the main protein. So in hemoglobin you have a porphyrin ring, right? So in P450s you have the ferry porphyrin 9, so you want to take note of that. So it's ferry protoporphyrin 9. So this is the Roman numericals. Now the structure is shown in the next slide. So cytochrome P450, here you have the iron atom in the middle, surrounded by the 4 nitrogens, porphyrin ring, and this is the outside is basically what's known as the prosthetic group here, which I'm circling around. The prosthetic group is defined as a non-protein structure that is bound tightly to a protein and is essential to the activity of the protein. So the porphyrin ring is the most important part. So this is the center with the Fe, the iron and the nitrogen. But the prosthetic group is a ferry protoporphyrin, which is found around the outside. So yeah, and it's 9, ferry protoporphyrin 9 prosthetic group. So usually, because cytochrome P450 is usually involved in oxidation reactions, you want molecular oxygen as a requirement or a cofactor. You also want NADPH, and we'll go into a bit more detail of how that works. Cytochrome P450 reductase. So whenever these reactions take place, you always want these 3 factors involved. So you want an oxygen molecule, you want an NADPH which can give up an electron, and you want a cytochrome P450 reductase which contains the NADPH and gives the electron to the cytochrome P450. Now we'll go into a bit more detail of why it has to do that and how it does it. So usually the location, which is mentioned here, P450 is in the terminal oxidase component of an electron transfer system, and it is found in the smooth endoplasmic reticulum. So I want to take a note of that. We'll make it into control bold. It's found in the smooth endoplasmic reticulum. Now, how does it work? So topology of P450. So simple. So you have this smooth endoplasmic reticulum here, and you've got the bottom part which is bound into the smooth endoplasmic reticulum. You have the cytochrome P450 around here, and you also have the cytochrome P450 reductase, which contains the NADPH. Now, usually, first what happens is substrate binds, and then so this is the substrate. So you have the benzene ring here, and this is the active site, the yellow bit. So once a substrate binds, an oxygen associates with the Fe, right? So remember, we have the essential factors or the cofactors needed are an oxygen, NADPH, and cytochrome P450 reductase. Okay, so once that binds, now one oxygen is usually prior to this. What really happens is, if you want to take this down in note form, and I think I might have it written somewhere. Yeah, so if we go through this in a bit more detail, right? So let me just find where I've written it out. Yeah, so the lipid soluble substrate binds to the active site of the cytochrome P450. This causes a conformational change in the shape. So the first thing that happens is the lipid soluble substrate binds, as you can see, the yellow bit. I'm sorry for sorry, it's a bit unclear. The next step is the conformational change leads to the iron atom in the heme porphyrin, so the middle bit, which contains the iron and the 4 nitrogens, and around the outside is a prosthetic group, if you remember. So the heme here is in the Fe3 plus state, and it accepts an electron from the NADPH C450 reductase, causing the iron to become reduced to Fe2 plus. So the key point you need to understand is, first, the substrate binds to the active site. This causes a conformational change. The conformational change then induces the cytochrome P450 reductase to release an electron, or donate an electron to the iron atom, which is in the Fe3 plus state. It accepts an ion, so therefore becomes reduced to Fe2 plus state. Now, the oxygen molecule that we talked about, which is an essential requirement or a cofactor, then has the ability to bind to this Fe2 plus because it can form a complex. Then the Fe2 plus donates an electron to the oxygen. The oxygen becoming oxidized back to Fe3 plus and O2 minus. So it gives one of its electrons to the oxygen, which then makes the oxygen negatively charged, and the Fe3 and the Fe2 plus is oxidized back into Fe3 plus. Now a second reduction, which is the important part. So you have a first reduction, and then you have another reduction in which the porphyrin accepts a second electron from the NADPH cytochrome P450. This electron is accepted by the already negative oxygen minus to form a superoxide. So this one's not accepted by the iron. It goes straight. We don't exactly quite understand the mechanism. It might be accepted by the iron first and then passed on to the oxygen, but we haven't confirmed that. So for now, you just need to know is in the second reduction, the oxygen again gains the oxygen to form a superoxide. So Fe3 plus is bound to an O, which is then bound to an O2 minus. Right, this O2 then binds to H plus, so this forms water, and the other oxygen is bound to the substrate, making it more. And the leftover oxygen, so once this O2 minus combines with water, so the H plus to form water, the leftover O, which is here, goes and binds onto the substrate here to form some sort of an epoxide, or whatever it hydroxylates it basically. So an oxidation occurs, making the substrate more hydrophilic and more polar, thus increasing the excretion. Now, if you ever want to, if you didn't understand this quite so well, you can always head down to this website, which was suggested to us on our lecture slide. This is our lecture slide. You can, go to elearn.pharmacy.ac.uk cytochrome P450. If you just type that into Google, there is a great animation that they have on how the topology of how the cytochrome P450 works. So this is basically the simple overview of how the CYP450 works. Now, so I'll leave this slide for a second or so you can grasp all the information and take notes if you need to. Yep, so let's move on. So this is the P450 cycle. So this is basically what we explained earlier. Now, we'll go into the different types of oxidations in a bit more detail. So aliphatic hydroxylation is the first one. So going back to your A-level chemistry or your GCSE sometimes, but it's mainly A-level, you'll be much aware of this is a CH3 bound to an R group, so it's a very long molecule, a side group. And what you're interested in aliphatic hydroxylation is this CH3 here. So you always want to put the arrow and then you want to put the oxidation. Oxidation is represented by this symbol here, O, and in brackets. Then you basically simply remove, because you're hydroxylating it, you simply add a node to the one of the hydrogens, so it becomes hydroxylated. So an example of this is tolbutamide, which is used in treating diabetes mellitus, or a hypoglycemic agent to treat diabetes, relatively short acting. So in terms of aliphatic hydroxylation, what you look for is simply first look for the alkyl chain, so the CH3, and then you got the rest is the R group. You go there and then you simply add an O, CH2OH, so it makes the hydroxylation. So this is hydroxylated aliphatic hydroxylation. And don't forget you have to put the oxygen and the symbol here as well. You can also write C450 reductase oxygen on the bottom, just to get your mind or understanding around it. That Cytochrome P450 usually requires that. Now, aromatic hydroxylation is also very similar. So you've got benzene here, and you simply add the oxygen. An example for the salicylic acid is an analgesic or a psoriasis, so skin burn, like anything that can happen to your skin. You give salicylic acid, and this is converted into gentisic acid via oxidation. So the main compound that you're looking for, the main structure that you're looking for, is this benzene ring, and you simply add an OH to form the gentisic acid. Okay, so that's aromatic. So first one was aliphatic, aromatic. Next one's another example of aromatic, so lignocaine, which goes into 3-hydroxylignocaine. Is an anesthetic as well as antidysphenic. So again, you're looking for always be careful to put this O in the thing. But again, you're looking for the main benzene. So whenever you have aromatic hydroxylation, you look for the benzene, and you simply find a spot where you can add an OH. So here is a 1. So if you start numbering it, you have 1 here, which is like the main group, 2, 3, hence why it's called 3-hydroxylignocaine. Okay, so you always put it on the third one. This is the main functional group. It contains the biggest molecule, so therefore it'll be 1, 2, 3. It won't be 1, 2, 3, 4, or it won't be 1, 2, 3, 1, 2. It'll be always 1, 2, 3. So there's a third one. It's attached to the third carbon in the chain. It's called 3-hydroxylignocaine. Yep. Next one is epoxidation. So I mentioned earlier carbamazepine, usually used to treat, it's an anticonvulsant, usually used to treat epilepsy, so seizures. Again, here you look for the main thing that you're looking for is a benzene ring, and you simply add an epoxide to it, which is like this, a no. So here you can see the example. Benzopyrene found in cigarette smoke. Now, dealkylation is very important because the product, you need to know the product, the byproduct, and what you start with, and the what you end up with. And so in P450 oxidations and dealkylation, oxygen. So think back to when I first mentioned what dealkylation was. There's 3 different types. There's N, there's S, and there's O dealkylation. So you have ether. So what you're looking for is you're looking for is an ether. In O oxidation or O dealkylation, you're looking for an ether. So this is basically an O in the middle with molecules on either side, and then again, can't stress enough of how much you have to put O. This usually breaks up here in order to form an alcohol, and then it also forms an aldehyde. Right, so always to be careful is that the main thing for O dealkylation, you always get an alcohol and an aldehyde, but for an N dealkylation, you won't get an alcohol, but you always, the main byproduct of all this is an aldehyde. So phenacetin is the old version of paracetamol. So usually once it's administered as phenacetin, it gets dealkylated into paracetamol. So you can see first what you do is there's an O-type O dealkylation reaction. So you look for the ether. So simply come down, there's the R bit. This whole here is the R bit, and then the CH2H5 is the alcohol bit. So you look for that, and then you break it there. So then therefore you get your phenol, or your OH. So there's the paracetamol, and then you got the acetaldehyde, CH3CHO. So always the key stress is this bit here and aldehyde. So in O dealkylation, an example is phenacetin. So an analgesic related to paracetamol previously used to treat pain, but nowadays is mostly paracetamol that we use commonly. So might want to remember the structure of what paracetamol looks like, and you always get an acetaldehyde, or commonly referred to as aldehyde. So again, O dealkylation, you get an aldehyde. Now another example is codeine. Here you simply again go back and look for an ether. So first you can see an epoxide here. So can't do anything to that. Then you come around, look around, and you can find the R group, which is all of this, and the CH3, which is here. So you found an ether. So you can form that as an OH, and then you form that as C2, an aldehyde. So basically an aldehyde. And what you end up with is a molecule called morphine, which is an high-end analgesic pain reliever, usually administered intravenously, but very high dosages can lead the patient to go into coma. N-dealkylation usually occurs in tertiary amines. Deamination usually occurs in secondary amines, but N-dealkylation usually occurs in tertiary amine. So what I mean by tertiary amine is usually an amine group has an NH3. So if you've removed all 3 hydrogens, then it becomes a tertiary amine. If you removed 1, it's a primary, 2 to a secondary. So in this case, you can see that there's no hydrogens bound to the N nitrogen, so therefore it's removed all 3 hydrogens, so therefore becomes a tertiary amine. And when this becomes oxidized, so you usually get an amine, primary amine, because we've got a 1H back again, and then you have an aldehyde. Similarly, S dealkylation is also very similar. So you start off with a sulfide. You simply add an H here. Instead of the O, you add a H here, and then you have an aldehyde. So the main thing that you need to understand is all these dealkylation reactions always produce the byproduct as aldehyde. And that's the main concept that you want to take away from dealkylation. Always remember the dealkylation always produces an aldehyde, and in terms of O dealkylation, they also produce an alcohol or a phenol or something. Fifth one is deamination. So this is a process of removing an ammonia. So deaminating. So you can already tell a byproduct will be NH3. And what you're looking for is, in terms of this, is you're looking for an amine group, which is a secondary amine. So as you can see before, in N-dealkylation, we were looking for a tertiary amine, which has no hydrogens bound. Now we're looking for a secondary amine. No, sorry, we're looking for a primary amine, which is bound. Which is bound to a null group. So something like this would be broken down via deamination. So you simply break it off here, and you end up forming an inactive metabolite or a ketone. So you always get a ketone and an ammonia when you in a deamination reaction. The product is a ketone, and the main thing that you want to take away from this is the byproduct is always ammonia. An example of this amphetamine, which is usually sympathomimetic. So you can see that all phase 1 metabolism doesn't always make the drugs more active. Here, in this sense, you can see that amphetamine has become an inactive metabolite, so it's completely useless now. So there are some metabolisms that you want to try to avoid, but these are the common reactions which take place when these sort of deamination takes place. So again, you look for this group here, so NH2 and then or something bound to nitrogen, and you simply you oxidize it, break it apart here, which means you end up forming an NH3 ammonia as a byproduct and then a ketone. So the sixth one is N-oxidation. So in this case you look for a secondary amine, so one which has lost two hydrogens. So in this case you can see, so you look for a secondary amine, and in this case you simply add an OH group, so hydroxylamine, which is very toxic. So clozapine is an antipsychotic drug which is usually prescribed in schizophrenia, for treatment of schizophrenia, so some sort of fear or something, so psychic. And what you simply do is you simply just add an O to the top part of the N. And X oxidation is also similar. You look for something like that. So don't get it confused with an S dealkylation. So you always get an aldehyde in dealkylation. And here you don't have any byproduct of N oxidation, and S oxidation don't usually have a byproduct. Now, alcohol oxidation is probably very familiar to you. Most of you could probably go out on a Friday night and then end up consuming too much, and then you wake up the next day with a banging head. And I'll explain why that is. It's because your body usually converts ethanol into this When ethanol is oxidized, it usually forms aldehyde and water, and it's aldehyde that causes this nausea slash headache effect that you get, which you call a hangover after a night out. But what you need to take, the key point from here is it's usually oxidized into an aldehyde and an H2O. Dehydrogenation is paracetamol can be dehydrogenated into NAPQI, which is N-acetyl P-benzoquinolamine, which is an antimalarial drug. Paracetamol is what happens is dehydrogenation is the removal of hydrogens. So you simply, what have we done here? Sorry about that. So here you have the OH. So you remove the hydrogen. So you simply get you're dehydrogenating it, and the byproduct is always water. So you want to try to take out water significantly. Dehydrogenation is quite rare, but it's usually removal of things. So if you were to go back very quickly and go over them in a very, very, very rapid manner, maybe in a minute or so. So you have highly fatty hydroxylation. You look for a CH3 and you simply add an O, which makes an alcohol. So it's hydroxylation. An example is dilbutamide, which is used in hypoglycemia and diabetes mellitus. Aromatic is simply similar. You look for a benzene and then you add an OH. An example is salicylic acid, which goes into gentisic acid. Lignocaine, added to the third one, 3-lignoprocaine, 3-hydroxylignocaine. Carbazepine is apoxidation, used to treat epilepsy. So you look for a benzene again, and you add this triangly oxygen here. Benzopyrene is found in mostly commonly carcinogenic. We can induce malignant tumors. So stay away from the cigarette smoke and stuff. And what causes that tumor mutation is a molecule known as benzopyrene, which then gets converted into benzopyrene 4-epoxide, which can then alter DNA mutations and DNA synthesis. Dealkylation, you have various different ones. You have oxygen dealkylation, N dealkylation, and S. The O dealkylation is always forms an alcohol and an aldehyde. So the main thing that you're looking for is an ether, so which is an O in the middle, bound to two different groups on either side. So you end up having an aldehyde and an alcohol as a byproduct, and the byproduct is aldehyde. Example is phenacetin, which is the older version of paracetamol that they used to treat analgesics. So you break it apart here and you end up having paracetamol and you get an aldehyde. Codeine, morphine. N-dealkylation usually looks for tertiary amines, and you get an amine and an aldehyde again. And S, you look for something similar to this. And so whenever you're doing dealkylation, a key point is you always look for a CH3, an alkyl group. Always look for an alkyl group. So you found an ether, but you want to also confirm it by looking for an alkyl group, which is a CH3 here. Similarly, here is the tertiary amine. So you've got the N, and you want to look for an alkyl group here as well. And in sulfide, you also again want to look for an alkyl group. And then the main takeaway message is they all form an aldehyde as the byproduct. Deamination is phetamine is an example. You basically look for an NH2 and they form what's called a ketone and ammonia. So the byproduct is ketone, byproduct is usually ammonia. So amphetamine is an example. N-oxidation, clozapine, secondary amines you're looking for this time. So you want to look for an amine. Right, so you add an oxygen here, and you got S-oxidation, sulfoxide, sulfone, ethanol, you get aldehyde and water. Dehydrogenation, you also get water being produced. An example is paracetamol going to NAPQI, which is an antimalarial drug. Dehalogenation is quite rare, so it's the removal of and halogen, so bromine, chlorine. So why, you might be wondering, you can't remove the fluorine here is because it's bound to carbon already, so it's much harder to remove it. So you simply remove the ones that are removed first. If you want to remove this, you would have to remove a CF3. So you remove the bromine and chlorine, which then you end up with a ketone again. You end up with a carboxylic acid. Let me just type that in. Carboxylic acid. Yeah, so I hope you've all understood that. The next lecture is going to be on phase 2 metabolism. Well, not phase 2, we're going to carry on with phase 1. So all of this was P450 associated oxidation. We're going to carry on with non-P450 oxidation, reduction, and then hydrolysis, and then move on to phase 2 metabolism. And then after that, we'll hopefully look at some questions, different types of, we'll go through toxicity and stuff like that. So I hope you guys enjoyed the video, and thank you for tuning in, and I'll see you in the next lecture.